kind. And Associate Professor Yates, you've now, I think, only got about 7 minutes to give your half-hour talk because you asked too many questions.
That's the other Yates.
Yeah, exactly. So, Associate Professor Paul Yates, geriatrician and clinician researcher with expertise in dementia and geriatric medicine in hospital and community settings. He's an Acting Director of Research Continuing Care Division, Austin Health, and Acting Director of the Cognitive Dementia and Memory Service, as well as Clinical Associate Professor with the University of Melbourne Department of Medicine, Austin Health. He also has extensive experience as Principal and Sub-Investigator on more than 20 clinical trials in Alzheimer's disease. And you're going to talk to us about the donanemab in early symptomatic Alzheimer's disease efficacy and safety from Trailblazer ALS2 long-term extension. Thank you.
Thank you.
7 minutes.
7 minutes. All right. I can talk quickly. I didn't realise that screen would be there. That's why I brought my laptop up. And this is good because I don't have to try and click with one hand and click with the other hand at the same time. So thank you for having me, and thanks to Lily for supporting me to present this today. It gives me a great pleasure to present the long-term efficacy and safety data from Trailblazer ALS2. Here are some disclosures. I have received honoraria from Lilly, Eisai, and Novo Nordisk, and also acknowledging all of the contribution from the teams from Lilly and also participants and sites to produce this data that we're presenting today. So we've heard a lot about Trailblazer ALS2 in the placebo control portion of the study, where it demonstrated the benefit of donanemab compared with placebo with limited duration dosing. As we see, that was about 1,700 people over 18 months. It reduced there was reduced treatment duration based on clearance criteria. So people who had a PET scan which demonstrated a significant lowering beneath the threshold for positivity. 47% of people were able to be had their treatment completed at 52 weeks and 69% at 76 weeks. And then when we look into the long-term extension, it followed people who were in the Trailblazer ALS2 study for another 18 months. So there was a delayed start group as well as the early start group. And people within the early start group, if they still had evidence of elevated amyloid, they continued on treatment with donanemab as obviously they were blinded from the original study. People in the delayed start group continued to have blinded infusions based on clearance. So again, if they lowered their amyloid below the treatment threshold, they would also go on to placebo. So what we saw in the placebo control group, obviously there was a placebo group to compare to, but in the long-term extension, there's no placebo group. So what the study team did was to compare the donanemab-treated patients with a propensity-weighted external cohort of controls from the ADNI observational cohort study. And this shows the tracking of the ADNI controls with the placebo group. So during the first 18 months, they were very well matched for clinical progression to the progression of the placebo group. And you can see then there they track over the 18 months following. To determine what would happen next, there were a couple of potential scenarios. So these hypothetical scenarios could be mapped out, and then we can see what we actually observe when we look at the trial data. So the first scenario might be that the lines of change in CDR sum of boxes converge during the long-term extension period. And this would suggest that there's a waning of a treatment effect once you complete the treatment. The next hypothetical situation would be that there's parallel lines, so that shows that the benefit is maintained, but there's no widening. And what I guess we would be hoping for in a true disease-modifying therapy would be to see continued widening between the placebo group and the people who were commenced on treatment early, to suggest that there is evidence of disease modification with increased benefit over time, even though people may have actually completed their treatment. And this is what we saw. So when we looked at the early commencement group versus the ADNI control group, you could see that the lines do widen. So there's evidence that there's treatment benefit increasing, even though the treatment regime has been completed in the majority of these participants. And so you can see that the donanemab benefit continues to grow over 3 years compared with the external ADNI cohort. And this is relevant to what Mark's presented. The delta changes from 0.6 to 1.2 at 36 months, but these are group-wise differences. So these are averaging out the difference between the two groups. Nearly half the placebo-treated people who were on placebo in the first 18 months actually had progressed to moderate dementia by the start of the long-term extension. So there was a question that was coming up, what do you do with people who have moderate AD? And so you can see that at the start of the long-term extension period, the people who were delayed start, so who didn't have treatment in the first 18 months, the mean CDR sum of boxes for that group is 5.7, and 45% of those people had a MMSC of less than 20, which was what they used to define moderate AD. In terms of efficacy, across the entire period, the early start donanemab group showed 27% reduced risk of progressing to the next clinical stage, so on CDR global score, so that's 0.5 to 1 or 1 to 2, for example. And there was a continued difference in continued sort of treatment effect, continued difference between the early and the delayed start groups over the period. The lowering of amyloid in the delayed start group was broadly consistent with what had happened in the earliest groups. So you can see the early start group at 24 weeks, the mean lowering of amyloid was 62 centiloids. And the delayed start group at similar time frame was 61. So you can see that the two are broadly comparable. And in people who had cleared amyloid and met sort of treatment completion criteria by 52 weeks, their mean amyloid levels remained low, so below the threshold that was set of 24 centiloids. They stayed down for 3 weeks. And so they've hypothesized that the accumulation rate of 2.4 centiloids per year is comparable to a natural accumulation rate in this study. In terms of safety profile, the cohort that commenced later had a similar safety profile to the group that was commenced early. There were comparable frequencies of ARIA and infusion-related reactions in the delayed start group with that's been presented in the placebo control component of the study. With the longer duration of follow-up, the people who were on donanemab in the placebo control period, their safety profile began to more closely approximate those who were on placebo from the start. So the rate of mortality, serious AEs, and discontinuations and other things all started to come much more closer together. And interestingly, the ARIA frequency, the difference in ARIA frequency also, as you might expect when you follow someone for longer, starts to get closer together as well. So the people who are on placebo in the placebo period had 2% incidence of ARIA-E, and that was 3.5 in the donanemab initiated in the placebo period group. So to summarise it, I've gone a little bit faster than I might have otherwise, but to summarise, the long-term extension data showed that there's clinical efficacy benefit, so continued separation of the curves, continued growth in clinical efficacy benefit over 3 years, that the delayed initiation of donanemab group also did benefit, even though a higher proportion of them were of moderate severity at initiation. And the group that started early over the 3-year period had a 27% reduced risk of clinical progression on the CDR global score. In terms of biomarker efficacy data, both early and delayed start of donanemab showed a very robust and consistent amyloid clearance in the realm of 86 centiloids over 18 months, and that clearance below 24% threshold was achieved by more than 70% of early and delayed start participants within 1.5 years of starting. The reaccumulation rate was consistent with what's seen in the an observational cohorts at about 2.4 centiloids per year, and there were no new safety signals observed compared with the established safety profile from previous studies. So yes, over 3 years, donanemab-treated participants showed increasing clinical benefits despite most of them having had their treatments stopped and a consistent safety profile. Participants initiating donanemab after 18 months did demonstrate benefit in disease slowing on treatment, and this really reinforces the importance of early intervention and supported in this situation with donanemab a limited duration treat to target dosing and continued long-term benefits. Thank you.
Shaved about 20 minutes off your talk.
Excellent.
We heard earlier today that the amyloid accumulates at about 4 centiloids a year in a natural population. The Lilly data suggests 2.4. Do you think amyloid reaccumulates more slowly after you have cleared it?
I was going to ask Colin the same question. Do you want to just pass the microphone to the right? I was wondering that as I was reading this data, it's certainly they're reaccumulating more slowly than other observational cohorts. So I wonder. And if you've shown, I don't want to hypothesise as to mechanisms, but I think it's a possibility. Do you, Colin? Yeah, don't know. Oh, Chris.
Looks like amyloid clearance might plateau after 76 weeks, so you keep treating, but you don't actually get rid of any more amyloid. So why would you keep treating? Would you be better trying a different antibody?
Yeah, I wondered about that too. So people who hadn't cleared within the 18 months did continue on treatment into the second 18 months. I don't have the data to my fingertips as to what happened to people if a proportion do clear in that group, because that's not what was presented here. So I don't think we know the answer. It would be good to have more information about these people in detail. I don't think that we've done that analysis, Chris. But it's a good question. And maybe these are people were these people who started at very high? Or is there something different about these people that they're not responding in the same way? I'm not sure. Mark?
Thanks, Paul. I guess there's two questions. One is that it seems, as I understand it, the population that's in the long-term group that is become that is in the late treatment group were a population of people who were placebo and then switched, as well as the population who were cleared and then observed because it was placebo controlled. Nobody knew other than the investigators if someone at 12 months was cleared, they would become placebo, but they wouldn't know. Nobody knew the difference. They separated out. That's the first question. The second question is, you've got group data there, and yet you've got a mixed population with a mean MMSE score of 19, and I'm pretty sure there'll be. I think we need meaningful within-patient data about in different subgroups of MMSE or different levels, I don't know, of tau when people switched, to be able to understand what that average really means. Because at the moment we've got an average with a mixed population, we might find that the population who really weren't responding and weren't clearing amyloid and now get it, or had a very lower MMSEs, were worse off and didn't actually get the benefit. But the subpopulation within there that had a higher MMSE score, so in other words hadn't progressed as much, then looked like they got more benefit, which they might well have done, and that's making the group, that's defining the group difference.
I'm just trying to keep track of your first question. So I think, I'm not sure if I'm answering it correctly, but the site teams were blinded to allocation throughout, and so people changed from active to placebo, but for anyone's awareness, they were just receiving the same thing. So no one knew their allocation. At the back end, obviously, the team that did the analysis knew, and I think that the early start group includes people who were treated to clear. They stayed in the early start group in those analyses. They didn't join the other group. The delayed start group were on placebo for the first 18 months and then commenced infusions. If they cleared, they stayed in the delayed start group, but blindly they were put onto placebo once they cleared. Does that make sense? For the second question, this data has only been presented, it's not yet published. I'm sure that they will be looking at within patient differences, because I think you and I agree that's a more interpretable way to present the data. The only within patient difference we had here compared the group that was started at the beginning to the group that was started late. And that was a 27% reduced rate of progression to the next stage of CDR over that period. So I think that makes donanemab look less good than it is, because it's comparing early start with late start rather than early start with placebo. So I think if we looked at the early start versus placebo over 3 years, we hopefully would see a much bigger separation consistent with what was seen with the group difference. Yeah.
So is amyloid reaccumulation rate related to the amyloid burden?
Good question. Yeah, it should. Well,
The data
I mean,
should be
the
there.
accumulation. Those who look at the. So, there's no. The rate of change of amyloid in those who are looking at accumulators versus. Haven't you shown some data that showed at different stages the rate of accumulation can be different, though, Colin?
Once it takes off, it goes straight up.
Goes straight, and it does.
And then it plateaus.
Then it plateaus, and none of these people. Well, we don't know where they were in that point.
But you don't know the effect of donanemab. I mean, I accept that's in disease-free state, in treatment-free state. But what is the effect of donanemab in the accumulation rate in relation to amyloid burden
Once they've cleared, or once the.
in the process of?
Yes.
That's what Michael asked.
We don't know. Well, I don't know. Lily might know. They're gonna take it on notice and take it to John Sim.
Hi.
So we're getting.
Hi, Paul. Hi again.
Oh, hello.
So I'm Paul Bray. I'm a medical oncologist and geriatrician at Cabrini Private Hospital. I'm hoping to start up an infusional centre and hoping to make Cabrini a trial centre too for dementia. Is there any data from Trailblazer of patients who subsequently had a heart attack or a stroke or developed atrial fibrillation, and if they were started on anticoagulation or given fibrinolysis?
I don't have that at the tip of my head, but I think that so people on antithrombotics were initially permitted in that Trailblazer study, and there was no association over the broader sort of donanemab-treated population between antithrombotics and ARIA. In terms of, they've done a bit of a deep dive into risk factors for ARIA over the course of the treatment. So most of the specific concerns about antithrombotics have come from my understanding, from the lecanemab studies. On the TGA-approved label, antithrombotics are permitted, but there's a caution against their use, obviously. So I think this is an area where post-marketing surveillance is going to be really important, and the registry information is going to be really important, so we can understand exactly what the risk is, that we're not throwing out babies with bathwater, and that we're not having people miss out on potentially beneficial treatment because of these medications. So that's my answer. And I confess I'm not within the study team, so I don't have all of that information right here. But I think the answer is there were some, and there's not been any association in that group. We're going to get Mariam.
We can provide the breakdown of the proportion of patients different and that's useful. So I can have a chat to you during afternoon tea.
We'll introduce you to Mariam. Thank you.
All right, we might, in the interest of time, I'm sorry, trying to be yes, keep things moving. All right, thank you very much, Mark. Our next, sorry.